talking about chapter 22, the anticonvulsant drugs. And to talk about the anticonvulsant drugs, I first want to talk about the neuron and its role in making a skeletal muscle contract. So here I have drawn a neuron, and I have the dendrites, the axon, the axon hillock, the axon terminal. So what happens for an axon to get excited or to create an action potential is that it receives input or graded action potentials from other neurons, and they come through the dendrites, and many times they're excitatory. So this creates an action potential that causes sodium to influx. So there's a change in state. Normally, the resting membrane potential for a cell is negative because they want to create a change. They want to create a signal, and the only way to create a signal is to cause a change. For example, when you're in class, you raise your hand, so you're creating a change indicating that you know the answer. So this is what the axon does. Like it's normally has its hand down, meaning like it's negative, and then when it wants to create a signal, it puts its hand up, or it causes influx of sodium, and it travels down the axon to the terminal where it releases neurotransmitters. I have written here, I have drawn here another neuron and its role. The reason I drew it is because sometimes what happens is that neurons can inhibit other neurons. So we have the signal, it's perfectly fine, it's going to travel, but it's being stopped by the release of gamma aminobutyric acid, also called GABA. And what GABA does is causes chloride to rush into the cell and potassium to come out. Chloride is negative, and potassium is positive. So the negative is going in, the positive is coming out, causing the cell to hyperpolarize. So what that means is basically become very negative. So this causes, it's more difficult for the neuron to fire an action potential. It's harder for sodium, for there to be an influx of sodium. So this is the inhibitory effect of GABA from another neuron. The reason I have little pictures here is because some of the drugs that we're going to be talking about, they either increase the GABA effect or they suppress sodium influx, so that signal isn't sent. So I have here a neuron in the periphery, and it's leading to muscle, and the neurotransmitter that is being released is acetylcholine. And what happens once acetylcholine binds to receptors, it causes a sodium influx, and that unlocks channels that cause calcium to be released into the endoplasmic reticulum. And of course, I think you've learned this already from physiology, that it binds to the troponin-tropomyosin complex, and the sliding filamentary, where the actin and myosin, they contract the heads, and that causes your skeletal muscle to contract. But this is a bad thing when the neuron is constantly firing, because it causes convulsions. And that's what we're going to be talking about. We're going to be talking about seizure disorders, and for that I've drawn out a table. I've combined two tables that are in the book, and that's table 22.1 and 22.3. And what we have in the columns are seizure disorder, explanation, and drugs. So let's start off with the first one, tonic-clonic, also called grand mal, and it's under generalized seizures. Generalized seizures involve two hemispheres of the brain, and what tonic-clonic is, or what it presents as, is the tonic phase of it. There's muscle contract, so you're just contracted for 2 to 5 seconds. You're going to see the people contracted, and the clonic part is that after the muscle contracts, you're gonna randomly dysrhythmic contractions for around 2 to 4 minutes. This is the most common type of seizure. The next I'm going to be talking about is partial. This only affects one part, the one hemisphere of the brain. That's why it's called partial, like only a part. And there's 2 types, simple and complex. Under simple and complex, there's even more types. For the simple, the person is conscious, and one of the types that I wrote is sensory. And what happens for sensory is that they have hallucinations regarding taste, vision, and hearing. So they taste things that aren't there, and that's what happens in simple. But this is just one of the types. the other thing I want to talk about is complex. We're still under partial. Seizures. In complex, they aren't conscious of what they do. And one of the examples is that I chose is psychomotor. So they have repetitive chewing or swallowing, like, but they don't remember that behavior. There's also other things like that they randomly do, but they don't remember them. And so moving on to the next one, absence is very common in children. It lasts around 10 seconds. They don't have conscious. They're not conscious. It's also called petit mal, and it's under generalized again. We have these also in the book, myoclonic. What happens in myoclonic is that the person is conscious usually and have shock-like jerks. Atonic, A means without, tonic, tone, so without tone. So what happens with the muscles is they randomly become very limp, like the head or the body, it becomes limp, atonic. That's a type of seizure. Atypical means not typical, so this is a type of absence seizure, and the person basically they're in a stare. They might respond. They don't respond in absence, but here in atypical, they might respond. They also have eye blinking, chewing, lip smacking, or even a slight jerk. And again, we have absence, but the book puts it here because we're going to talk about the drugs that are used for these group of seizures. The last thing mentioned in the table is status epilepticus, and what that is just like a persistent convulsion. Sometimes it lasts more than 5 minutes, more than 30 minutes, and that's a real problem because a lot of damage could be caused. It's a medical emergency because there's overstimulation. So now for the drugs, we have for the tonic-clonic, we have phenytoin, carbamazepine, valproic acid, lamotrigine. So I know you don't know them yet, but I am going to go over them right now, but just remember a little bit that phenytoin, carbamazepine, valproic acid, lamotrigine for tonic-clonic. The next that I talked about was partial seizures, and for that one we use phenytoin, carbamazepine, oxcarbazepine, levetiracetam, primidone, phenobarbital, tiagabine, topiramate, sunisamide. For absence, not a lot of drugs work on absence seizures, so a very important one is ethosuximide, valproic acid, lamotrigine, clonazepam. Okay, the last, which was the group that we had discussed, valproic acid, lamotrigine, clonazepam, diazepam. For the status epilepticus, which we want like a fast result, we're going to use diazepam, fosphenytoin, lorazepam, and phenytoin. So now we're going to get to the drugs. Now we're going to start talking about the drugs. And the ones we have here, the first class, this is table 22.2, the purple box that the book has. So the first class are barbiturates, methylbarbital, phenobarbital, and primidone. So the way I remember them is like they're barbiturates, so like barbarians, and they are, so they're gonna have barb, and then primidone. So I put here barbarians are primitive and they're done, like there's no more. So because they end up barb, like barbiturates, like barbarians, methylbarbital, phenobarbital, and they're primitive. All the barbarians are primitive, so there's no more of them. So the most important one that the book mentions is phenobarbital. And what all these barbiturates do is that they increase the GABA that we were talking about, that it inhibits other neurons. The phenobarbital has a therapeutic range, 20. A lot of these drugs are going to have therapeutic ranges, so I'm sorry, 20 to 40 micrograms per milliliter. And the risk of phenobarbital is dependence. A side effect that can happen is we are treating it for anticonvulsion, but sometimes the opposite could happen, where they could actually have convulsions. Another thing, it's a P450 inducer, and I'm going to talk about what P450 is, but just keep in mind for right now that phenobarbital is a P450 inducer. I'm going to talk about P450 when we get to phenytoin. So primidone. So remember, methylbarbital, phenobarbital. The barbarians are primitive and they're done. So barb and then primidone. The book mentions to take with food to decrease GI upset. The next class is benzodiazepines, and those also increase gamma aminobutyric acid, and they end in zepam. So that's a common suffix. This is actually an appropriate suffix. I know I've made up like inappropriate suffixes before. This is actually an appropriate one. The zepam, clonazepam, chlorazepate, diazepam, lorazepam. So like zepam, zapate. So first, clonazepam. This is for an absence, for the absence that we talked, the seizures. But the problem with this is they might have a possible tolerance after 6 months of taking the drug. Its therapeutic range is 20 to 80 nanograms per milliliter. Chlorazepate, it's used as an adjunct drug, like in combination with other anticonvulsants. Diazepam, this is the one we're going to use for emergencies for status epilepticus. And it's IV. It's very short term, so after you give diazepam, you have to give another anticonvulsant, like maybe like phenytoin. This is a drug choice when someone is having constant seizures. Lorazepam. This is the last benzodiazepine. It's also used to treat anxiety, substance abuse, withdrawal. So you might want to remember that lorazepam, the brand name is Ativan. That might help later. So the next class, aminostilbene. We have carbamazepine, carbazepine. What this does, like we already talked about the neurons, it stops the sodium from influxing. So there's no firing because there's no sodium coming in. It's also a P450 inducer. I'm going to talk about that later. It has a therapeutic range, 5 to 12 micrograms per milliliter. It's not for pregnant people. It may call it Stevens-Johnson syndrome, and I'm going to talk a little bit about what that is also when we get to phenytoin. The reason we use this is because sometimes there's people that take a lot of drugs and they're not working on the person, so we give this drug when other drugs aren't effective. We also use it for bipolar, trigeminal neuralgia, and alcohol withdrawal. Don't drink with grapefruit juice. The last one is oxcarbazepine. So this one compared to carbamazepine is that it has less adverse effects. So the less adverse effects like the Stevens-Johnson syndrome. Okay, we finally finished this section. Okay, so now hydantoins. Yay, we're almost at phenytoin. So they're in alphabetical order. Fosphenytoin. What it does is it stops the sodium and calcium influx, the calcium that I showed you in the diagram, and it eventually turns into phenytoin. So now phenytoin, therapeutic range 10 to 20 micrograms per milliliter. It stops sodium influx, and because it's stopping sodium influx, it actually decreases heart dysrhythmias because the heart isn't because sodium is something that almost all your cells use, and your cardiac cells also. So it stops them from being stimulated, just like the neurons. But this is also, if you see the contraindications, you can't use it for heart block or bradycardia because it would slow the heart even more. Something you have to watch out for phenytoin when given in IV is you have to give it slow. You have to check the IV site because something that happens, extravasation in